National Development Research Institutes, NDRI. Welcome to the first part of the Neuroscience of Addiction. This is part one of what will be a three-part series running each Thursday for the next 2 weeks. So we've got part 1, 2, and 3. I'll be talking to you today specifically about how seeing addiction as a disease of the brain can influence your practice as a drug court practitioner. This webinar is brought to you by the Bureau of Justice Assistance, BJA Drug Courts Technical Assistance Project at American University, Washington, D.C., in collaboration with us here at NDRI, National Development Research Institutes. So before we get into the content, let's take a brief look at some of the webinar logistics, some of the things that you need to know in taking a webinar, just some ways that you can interact with me and I can interact with you. So if you'll take a look at your little orange arrow for the control panel. All right, that's the first thing you can take a look at. If you can click that, you'll see that your control panel goes off to the side. If you click it again, you'll see that your control panel comes back out. So you need your control panel to be able to ask questions of me, to be able to raise your electronic hand, and to be able to either clear your screen so you can see more of it, or to be able to access the control panel. So that's the first thing. Next are questions. The box towards the bottom where it says questions, you can click it open or closed. If you'd like, if I ask you a question and say please text in your response, this is the place you do. It's very simple. You simply type in what you want to say, hit the send button, it'll come to me on this end, and then I'll have a whole list of whatever anybody is sending in. So that's if I ask you to, if you have questions or if you would like to answer a question that I've asked of you as an audience. And then the third part is your electronic hand. I just love that saying, your electronic hand. So if you want to raise your hand, or if I ask you to raise your hand if you agree with something or disagree with something, this is where you will do that. So I tell you what, why doesn't everybody right now raise your hand, just so I can make sure everyone's not only listening, but little hands on my screen are going up all over the place. Excellent. All right, so you can, I'll take your hands down. I can do that electronically. It's always a nice thing to be able to do. And one final point is if there are any technical difficulties that you have with either sound or your screen that has to do with Citrix or our GoToWebinar folks who are hosting us, this is the phone number. This will be on most of the slides throughout the presentation in case something happens later on too, but it's always a good idea to take it down. It's 800-263-6317. So if you have any difficulties, you can call them and they'll get you back up online as soon as they can. They're very responsive. We've had very good luck working with them. Also, I want to say thank you to Clyde Fredericks, who is behind the scenes. He's our technology assistant who takes care basically of all the background stuff on this end, making sure, from my perspective, that the voice, this picture, and the screen, everything is in place. And of course, he makes sure that I'm ready to go. Okay, so who am I? I'm Joe Lunievicz, the director of the Training Institute at NDRI. About 20 years experience working in drug treatment as not only a provider, but also as a trainer of providers. And in the last decade plus, right, a trainer of drug court staff and a staff developer of drug court teams. And this area of neuroscience is especially close to my heart, not so much because of its technicality or its technical nature, but more because of the importance of neuroscience and what we know now of the brain and how addiction serves as a brain disease, how it can influence our practice, and how important it is to understand it to be able to influence our practice. So what are we going to cover then? Well, some of the things we think about when we talk about neuroscience is, first, what the heck is it, you know? And then second, you know, why do we need to know anything about it? And how much do we need to know about it? Because if you give me too much, we'll simply look at other work that's on our desk and move on. Well, neuroscience is important. You don't have to know a tremendous amount about it, but knowing enough to be able to see how a disease of the brain, specifically how addiction, drug addiction, works, can help you to see what you might need to be able to better your practice, to be more effective in your practice, to help more of your participants to graduate. And of course, graduation is a key marker for us, right? Because those of our folks who graduate regardless of how many times they relapse, right, or how long it takes them. But those who graduate, the research has been really clear on this. If you graduate, you're significantly less likely to relapse and to be involved in recidivist activities with regards to criminal activities. All right. So we'll talk a little bit about neuroscience. I'll give you some definitions that you'll need. We'll do neurochemistry light, and then we'll talk all the way throughout what the impact on our work as drug court practitioners will be. But we'll finish up with something that will tie that up. So here's my first question for you. I want you to think about why your drug court participants start using or for the first time try to use drugs. So why would anybody, although we can really think about our participants because you've worked with them and have more knowledge of this, why do our participants start? Why do they pick up the first time? Give me some of the reasons that you've come up with, that you've heard your folks say. So write them in your question box, text them into me, and I'll give you a listing of what comes up as they land on my screen. So I've got folks saying boredom, life stressors, to dull the pain of childhood, right? So medication for feelings specifically around how you were or were not taken care of. To escape. Now, what would anybody have to escape from in this world, right? Well, a lot of the folks that we've been working with, of course, have many things to escape from. Social acceptance, to be part of a group, someone wrote. Someone else, peer pressure. Peer pressure sometimes gets made into be this big joke, but it's really not, especially if you're working with young adults, if you're working with adolescents, but even for us as adults, the pressure of others in our environment can be tremendous, and it's a really important factor in starting, right? Coping with anything that's going on in our life. I've got someone else, peer pressure, too numb from feelings. It's funny to use the word numb and feelings together, right? Because usually numb means we don't have feelings, or I've heard people phrase it that way. But when we're numb, sometimes it's lack of feelings or too many feelings all at once, and so we shut down, right? I've got someone else who wrote in, they start because the drug is there, sometimes out of curiosity, sometimes out of trauma. That's fascinating to put them both together. For recreation purposes, because they're stressed, because there's stress in their life. Curiosity, experimentation. Oh, someone wrote, it's fun. Fascinating. Of course, so what you see here is a lot of reasons for folks to start up using substances, right? A lot of different reasons. And of course, if it works for you, then it's valid for you in that sense. So here's my follow-up question for you then. Why do your same folks over time, as time goes on, then continue to use those same drugs? So I want you to think about that. So the first question was, why do they initiate or start drug use? And now, why do folks continue over time to use those same drugs or to add on new ones? So why do they continue use over time? So put it in your text box and send it in to me. And they're coming in quick. Some folks, you guys are fast typists. I've got they are addicted and cannot stop on their own. I've got physical dependence, chemical dependence. I've got someone who wrote the drug works. Yeah, I mean, that's always fascinating to me. I think we forget that, people, we use drugs because they work. They do what they're supposed to do. And many of them are incredibly effective at doing exactly what they are supposed to do. I've got someone who wrote to kill the pain. Sometimes reasons that we begin to use substances are the same ones that we continue, right? Because they like the feeling, because there's a change in brain chemistry, because the drugs replace natural coping skills. Sure, so if it works, why try something else to help cope, especially if you've got something that is very effective? I've got lifestyle, develop a source of finances, and you don't want to stop, or perhaps feel like you can't. If you've ever been in a financial bind, you know what that can feel like. Formed a comfortable habit in coping skills. Maybe starting with peer pressure, someone wrote, to be part of the group, but then keeps them with those same friends. Why are you part of a gang? Well, because everyone's part of a gang, number one, and then once you're in, it's very hard to get out, right? Avoid withdrawal symptoms. That was the last one. That what someone wrote in, to avoid withdrawal symptoms. So there's a lot of terms in here which we're going to go over then in our hour together, everything from chemical dependence, physical dependence, brain chemistry, and withdrawal symptoms. But notice the shift in reasoning, how over time people's reasons for using drugs change. Sometimes they're the same. It really depends on what the original reason for picking up was. But many times they change, and many times it has to do very specifically with changes that occur in the brain, something we call dependence or addiction. So neuroscience, 40-plus years of work on the brain and trying to figure out what happens neurochemically, what happens to the brain over time when we're using substances of abuse. Addiction is a brain disease, and this is an interesting place to kind of come from if you think about it. NIDA has basically said that substance abuse is a National Institute on Drug Abuse, NIDA, right, has gotten behind this as a model. And there are many different models of substance abuse. Right? One is the disease model. There's biopsychosocial model, which we're going to talk about also. There's a moral model. There's many different ways to look at the reasons why people use substances. But these days, we're very much behind a scientific approach, which is, of course, for us, the best approach if you think about it, because what science tells us in this case, if we follow the logic of science, then we should be able to help support folks in reaching some kind of recovery. And if we're not following the disease model, then we have to ask ourselves either where is success coming from, do we know what it's coming from, and of course why we probably don't have as much success as those who are following the disease model. So you notice in the thought balloon we have with biological, sociological, and psychological components. And that just speaks again to the complexity of addiction as when looked at as a brain disease. I wish I could say it was a very simple process. It's not, but we'll see if we can break it down for you a little bit this afternoon. So what's all this fuss about neuroscience? What is it? Oh, by the way, when I said NIDA is behind the disease model, keep in mind that it's also the theoretical model, the underpinning for all of the evidence-based practices from NRAP, the National Registry of Evidence-Based Practices, that's listed in NIDA. The foundation of the science and evidence-based practices comes from the concept of the disease model of addiction or of chemical dependency. Right? So then what is neuroscience? According to dictionary.com, right, we've got the field of study encompassing the various scientific disciplines dealing with the structure, development, function, chemistry, pharmacology, and pathology of the nervous system that affect the brain. So talking about the nervous system, the spinal cord, but for us very specifically, the most important part that we'll be talking about is the brain itself. So every thought, every sensation, every emotion, every physical movement that we make is accounted for in terms of brain structures and brain chemistry, electrochemical process of messaging throughout our system, and then taking behaviors based on those messages. That's what it's all about. In other words, nothing happens in human behavior except by the mechanisms of the brain. So if we have a brain disease, then we can see how this is going to influence capability, ability to function, ability to follow plans, ability to follow through on actions, ability to exist in many ways. So the disease model of chemical dependency then, let's look at some of the components, right? So disease of the brain, meaning it impacts on the neurons, the chemistry, the pathways that we message in our brain, that it's a chronic condition that requires lifelong management. So chronic means that there's no cure, that you can be in recovery, but the chance to pick up again is always right in front of us. And that it requires lifelong management, right? So this can be a little hard to take in some ways because we'd like to think that we can simply cure chemical dependency or addiction and it can be done with and it never have to be dealt with again. But really it's a lifelong struggle that has long periods, hopefully, of stability in recovery, right? But which requires many times different kinds of treatment to be able to get there. So I find a helpful way to think of chemical dependency or addiction is like other illnesses that have similar characteristics, like type 2 diabetes, like chronic hypertensive disease, asthma, or obesity. They all have, a very complex web of physiological or biologically based, right, body-based, and behavioral health components. So they tend to be complex, right? Some of them need medications over time. Some of them need medications for life or treatment. Some of them need physical medications and or behavioral. Many need both, which can help to reduce symptomology and can help people to function better in life. Right? No one treatment episode resolves illness. So yeah, there's no cure to them, so we can't get rid of them. But we can, in a sense, hold them at abeyance. And in drug treatment language, we say we can have periods of recovery. So the course of dependency, then the course of illness, or the spectrum of illness, you could say, for addiction, is multiple episodes of treatment, recovery activities, relapse periods. And that tends to be what we see for not just the majority, but the vast majority of individuals. It doesn't mean everyone's going to follow the same path. Of course, that's one of the challenges of the diversity of human beings, biologically, psychologically, and socially, is that not everybody is exactly the same. Because there's so many of these different elements in place, the exact spectrum will be slightly different. But this idea of episodes of treatment, not just one, but multiple, many different recovery activities, changing at different times, and then having relapse periods is going to be important for us to kind of get in our heads, right in the forefront, right in the prefrontal cortex, and work with it as part of our decision-making process. Right. So let's then apply this. There's a phrase, I love to use this phrase all the time in trainings. The longer you're in drug treatment, the better you do. So why do we say that, and how can that, what is the research base for that? And there's a base in the way we look at brain disease, and there's also a base in the way we look at, for example, relapse. Right? So research has shown unequivocally that good outcomes are contingent on adequate treatment length. So how long does someone need to be in treatment? At this point, 30-day or 28-day rehab programs have really been looked at, and we know that they're not the most successful programs out there. Their efficacy is low. And one of the reasons is because we know that most folks are just starting the process at 1 month. If we know that the majority of relapse occurs within 30 days, 60 days, really up to 90 days, it's the most crucial time for relapse to occur because the brain hasn't recovered sufficiently to be able to help an individual to stay sober. They're much more vulnerable during this time period, especially the first 90 days. And when you look at brain imaging, as we'll take a look at it later, you can see what that means, that it can take not just a month or 3 months, but sometimes a year or multiple years for individuals' brains to recover from illness to some degree or to a more fuller degree. So if you know that, then what you can do is take steps. So generally for residential or outpatient treatment, participation for less than 90 days is of limited effectiveness, and treatment lasting significantly longer is recommended for maintaining positive outcomes. So this is an example of how we can take what we know about a brain disease, how it functions over time, right, and then use it in our treatment planning, right, and figuring out what to do with folks. So therefore, understanding how the brain functions during and after drug use. This is going to encourage all of us as practitioners to correlate, to select, to pick appropriate strategies to the stage of recovery. Knowing that there's different stages of recovery that our folks are in. They're maybe in pre-contemplation, contemplation when they first start off, which is also one of the reasons why those first 3 months is so challenging, right, because of where people are motivationally. And then therefore consequently impact on program retention. So the other thing that we know about drug treatment, for the same reason, knowing that multiple episodes will be important, is that retention in treatment is also very important. Retention in treatment of some sort, even if it's aftercare, right, is going to be crucial to long-term stable recovery. So let's take a look then at this thing called addiction. But part of the looking at addiction means that we also have to separate out drug use, drug abuse, and addiction. And there's all kinds of ways to look at this, and sometimes people add in their recreational use, social use, all different levels of the spectrum of use. I want us just to keep in mind right from the start that depending upon what type of use you have, You may or may not be addicted. You may or may not be abusing. But once you're using, you're somewhere on that spectrum of use. But depending upon where you are, how it's assessed during an assessment process, right? That's going to help to figure out what kind of treatment the brain disease needs, whether we have brain disease which is kicked in at a certain point or not. So, for example, abuse is a problem to solve caused sometimes by bad choices, sometimes by self-anesthetization, for medication of pain. Sometimes it's psychological pain. Sometimes it's other types. Sometimes it's from celebration or just wanting to get high. All the reasons you guys listed from the first question. Why do people initiate substance use, and then why do they then abuse it? Use so much that there are negative consequences of some sort. There's all kinds of reasons for that. Abuse is listed in the DSM-4, but it's not addiction, right? For abuse, many times when we have folks, depending upon a whole host of other circumstances, many times we work with them in treatment, outpatient treatment, education, positive reinforcement of alternative behaviors, coercion, environmental change, sometimes just through maturation all by itself. People kind of grow up and sometimes grow out. They develop new coping skills. We help them through life skills training. Sometimes pressure to stop, the loss of children, the loss of control over their life. Sometimes just life events occur and they get kind of shaken up and say, wow, this I can't do anymore. Sometimes time does that, but that's for abuse. When we move into the area of chemical dependency, we move into the area of brain disease, right, caused by three main areas, and these are the three we'll talk about: genetic vulnerability, drug use, and environmental influence. And it's the balancing of these three, or the imbalance of these three, how they work together, right, which helps cause brain disease. And of course, treatment then is to reduce through treatment, usually for our purposes, inpatient, just generalization there, but more serious when we have brain disease that's kicked in, when we have changes that have occurred to the neurochemistry of the brain. We want to have a little more intensive treatment to positively affect abnormal brain function, to reduce the need for the drug. And we're going to utilize, of course, in all of these evidence-based practices. So the key components in dependency then. You've got drug use or exposure to a drug. So the drug itself. You've got genetic influence or vulnerability. What's in the gene pool? What are you vulnerable to based on history in your family? And then environmental influences, things like people, places, and things. So this is, I found this absolutely fascinating. Drug exposure, who becomes dependent? So we all argue about these kinds of things, of all things to argue about, right? Like, what's the most addictive drug? Which is the one that gets you the fastest? Which is the one that hooks you quickest? So there's been some research on this, and I find it interesting because when we talk about addiction as a brain disease, it means that we have to look at one of the components of how addicting is a drug, how likely over a lifetime, if you use a substance for an extended period of time, not just initiated use, right, but we start to move into abuse and then continued use over time. Depending upon the drug, what's the lifetime prevalence of risk? So here's my list for you based on a number of studies. Nicotine is number one on the list, 32% chance. And remember, this is just based on the drug itself. It has nothing to do with genetic factors or environmental exposure, right? So just based on the drug itself. Got heroin, number two, at 23%. Crack, 20%. Well, you knew that was going to come up there, right? Cocaine, 17%. Alcohol, 15%, right up there in the top five. Stimulants other than cocaine, 11%. And on the second half, we've got cannabis, 9%, cannabis, right? Sedatives, 9%. Analgesic opioids, 9%. Psychedelics, 5%. And inhalants, 4%. So you'll notice it's not about the drug, its power. It's not about whether or not it does what it's supposed to do. All these drugs do exactly what they're supposed to do, and many of them very powerfully. It's about the estimated lifetime prevalence of risk for dependency, just based on the properties of the drug itself and its ability to damage the brain, the human brain. So this is an interesting question then. You guys tell me, what does this tell you? What can you infer from this, or what do you notice about these numbers on drug exposure? Is there anything that comes up for you? I'm just curious. Is there anything that's surprising? Text me your answer. Let's see what you got. So I'll wait a second to see what we get. I see someone says that they're surprised that nicotine is so high. Yeah, well, smoking's rough, right? And it's also, of course, one of our legal drugs. You'll notice 2 of the top 5 are legal drugs, so that's always fascinating. I've got other folks said society overreacts regarding cannabis. I never quite know how to pronounce that, whether it's the first A or the second A. Legality and availability of nicotine, yeah. We think meth should be higher. Yeah, that also fascinated me. I've seen other studies, but I left it in the stimulants other than cocaine. It seemed to me that it should be higher. And of course, if you're working a lot with folks who are addicted to meth, you know, it can make you, just by the visual image of a meth addict, bring it up higher for you. I've got meth should be much higher. That cocaine is so low on the list. Yeah, cocaine's 4, crack is higher. That makes sense because of its being inhaled right into the lungs. So some of it has to do with the way it's used also. What is legal is highest. Other than that, they're all fairly equal. Yeah, I mean, if you look at it overall, if you look at between inhalants at 4% and nicotine at 32%, that's a big range. But as you start to group them, you can see that there's a bit of a drop-off once you get to 9% and below. So it's an interesting list. But this is about all other things taken away, only the drug itself, its ability to help you to become dependent, right, based on the way it damages and changes your brain chemistry. Now let's look at genetic vulnerability for dependence. So basically, genetics means that, you know, at this point, the research on genetics has been pretty clear. The more family history you have who have been addicted to substances, who have been chemically dependent, the more vulnerable you are genetically to dependency, right? The more vulnerable you are. So what that means is that there are problems in what we call the pleasure pathway, the reward pathway, and that's what we're going to get into in a moment, because that's really where most drugs are going to function. That there's impaired control over drug use if someone uses a substance. The idea being that addicting drugs seem to match the need in the chemical system that is not normal. Usually what happens is if you've got, so let's use an example, you've got great-grandfather, grandfather, father, all were alcoholics. What's your chance of becoming an alcoholic? Well, first remember, it's not just genetic vulnerability. There's environment and the drug that's being used, right? So we know a little bit about alcohol, that it's in one of the top 5 as far as its chance for causing addiction is concerned. So it's a concern. But it means that if you start to drink, it doesn't mean that you will become dependent on alcohol, right? What it means is you're more vulnerable than someone who does not have that genetic history, right? So it means that biochemically, that neurochemically in particular, your body is designed to move towards dependency quicker than somebody else. So onset time is going to be variable depending upon how much history you have. And of course, it can range from mild to severe depending upon history on both sides of the family, how far back it goes. Again, remembering that it doesn't mean automatic dependency. It just means vulnerability, high, low, depending upon family history. So you can see already how these 2 factors can start to work together. All right, now let's take a look at our next one, environmental factors. And this is actually a model, a domain model by Dr. Kelly Lundberg from Utah Addiction Center at the University of Utah. I kind of like the way she lays this out. She talks about community domain, peer domain, family domain, and the schoolwork domain. All right, so community domain, let's think about this. Is there a lot of, what is the community like? Is it pro-drug use, anti-drug use? Not just in the sense of how do people feel, but what is actually going on in a neighborhood. Is there a lot of drug sales? Is there a lot of drug use? What are the drugs of choice? Is it similar to what the individual has picked up and is using? Even things like unemployment, homelessness, poverty, illness. Think about the list that you made in the beginning about dealing with pain. So pain comes in different ways. Psychological, things that people say to individuals, being beaten down or feeling like you're being beaten down by society, which of course many of our participants are in a similar place. Even think about what is the environment like with regards to how safe is your community. So if you're working with young black men, 15 to 34, where the leading cause of death is still homicide according to the CDC. Right? What is that like? What does it mean with regards to your choices for coping with stress, which someone wrote earlier as a reason to pick up, for fear, safety, right? Peers. So who you're hanging out with, what are they doing? Are they smoking weed, doing coke? What they do, there'll be a certain degree of pressure, more or less depending upon the individual's personality, the personalities of the individuals they're working with, the environment, how important is it to be part of that group, how old are you an adolescent where peers tremendously influence behavior, are you a young adult where the influence is still there but it's less, are you an adult? And let's remember, even adults are influenced by their peers, right? What are the norms that you're working in? Family domain. So family, love them or hate them, you got them. All right, one way or another, they're going to influence you whether you have nothing to do with them because they do by default, or if you're living with them, of course, they influence you in a very direct way. If you've ever seen people try to stop using marijuana or smoking cigarettes, for example, in a family where everybody smokes, not easy to do. So you start to put these factors together then, and you see how they work together. School and work, what are the values and attitudes towards substance use? How resilient are the individuals that you meet at these places going to help or hinder you? Are they beating you down, or are they helping you to meet goals in your life? How much opportunity in the school and work domain is there? So these can help us to motivate and move forward, or they can also influence the reasons for taking and continuing or extending our use of substances over time. So behavior, including addiction, is related to 4 things. Characteristics of the brain regions. So our brain, here's where we're going to get into the neuroscience. I'll try to make it light, folks, so work with me here. Characteristics of the brain regions, what does each part of the brain do? The functions of neurons, and neurons are the cells that make up our nervous system, and specifically the cells of the brain, including their connectivity into pathways or circuits. So when you have a path in your brain, it means you can do or access information, or you can behave in a certain way quicker because there's a path that gets you there quickly. So the development of pathways in our brain is very important to being able to survive as a human being, right? The neurochemistry that exists between neurons that allows them to interact. So the messages that go along these pathways are neurochemical. They're electrochemical, neurochemical. Right? And they exist. This is what exists between the neurons and allows them to interact, allows you to make decisions very quickly, almost instantaneously in many ways. So if your finger gets caught in the door, an impulse goes up to your brain and then back down to your arm to withdraw your arm from the door and to open the door in a very quick moment. Right? And if it didn't, then your finger could be caught there for quite a while. You might also yell out, ouch, that hurts, and stop, or something like that, right? So it's also the neurochemistry. And then, of course, external stimuli. So you're in a restaurant, a man pulls out a gun, and what happens? You've seen a stimuli. Some message came into your brain which said that is a gun, because you've seen a gun before, maybe directly, maybe on TV, maybe in work every single day. But you see this, you know what it looks like, and your body automatically reacts because there's a pathway set up that says fight or flight. And depending upon what your job is and how you've reacted in the past, that learned behavior will also influence how future behaviors are going to work. So external stimuli, right? So what are the players in the brain then? These neurons, which was just talked about, the cells of the brain, which, by the way, there's about 100 billion, and I put that there just because it just astounds me when you think about how many little guys there are in there, right? Little bits of brain power. I'm sorry, but the computer still has a ways to go before it can reach our 100 billion. And of course, these cells have all these different parts, which are dendrites, axons, and there's a cell body with a nucleus. And we'll go over a little bit what those mean, only in the sense of how neurochemically they function with each other. There are neurotransmitters, and these are the chemicals that communicate information throughout the brain and the body, and there's 50 plus and counting, and they're always learning about new ones. And the ones that we'll talk about, or the one we'll talk about the most, is something called dopamine, which all substances of abuse and addiction interact with and help the body to either modulate or dysfunction with in some way, shape, or form. But there's other ones like you may have heard of serotonin for alcohol, substance P for people who've experienced trauma, acetylcholine for marijuana, all norepinephrine, and epinephrine for stimulants. But dopamine we're going to come back to because it's really a neurochemical that gets emitted and sends messages to the front part of our brain when anything pleasurable happens, whether it's induced by a substance or whether it's food, sex, any kind of pleasurable experience. Right? So what is this? Where do they come together, and what's the important aspect of this? It all kind of coalesces in this one space called the synapse. And the synapse is the space between the axon terminal and the receptor dendrite where neurotransmitters flow. Now, those who just totally blinked out, come back to me, come back to me. The space between the axon terminal, basically the space between one neuron and the other, where the chemical message, the neurotransmitter, flows from one to the next. That's the synapse, and it's important because that's where drugs are going to start to impact on how we think, feel, and act. There are about 10,000 of these synapses per neuron. So we're talking about a lot amongst those 100 billion neurons, right? There's 10,000 of these synapses where chemical information is being passed. And this is basically what our two neurons look like, and you can see how information is going to pass from one to the next. Right? You've got the cell, the neuron's body. This is our dendrite. This is where information comes in. It goes down the axon to the axon terminal. The chemical neurotransmitters, they get passed across to this dendrite and it goes to the next one. Now, sometimes these can be very large, like this axon in the spinal cord can be a couple of feet long, believe it or not. But in our brain, of course, they're very small and very closely connected. Right? But this creates a pathway from one neuron to the other, and these pathways are going to be important for us. The things to remember is that there's this synapse, the space between where the axon and the dendrite meet. There's the synapse. That's the space right here. And you can see in this picture how neurotransmitters in red get a message from some stimuli, whether it's a drug or whether it's something that happens, an external stimuli in the world, to release the neurochemicals from these little sacs, these vesicles, into the synapse, where across the Great Divide are receptors, places for them to land. When they land, the message is complete. This happens in fractions of a second. And then, of course, they have to be taken back into their original starting place and placed in these vesicles all over again to do their job again and again and again. These here are what are called uptake pumps that after they do their job, these neurotransmitters come back. And there are also enzymes that are brought in to clear away anything that's left over after the interaction is completed also. So those three components are probably worthwhile just kind of keeping in mind. The idea that something releases the neurotransmitter and sends it across to send a message, right? And each of these neurotransmitters does something different. And then there's a mechanism to take once they've done their job, to take them back into their starting place so they can work again. And there's also a cleanup crew of enzymes which are going to get rid of anything else that's left in the synapse until it's needed to do its job again. So you want to have good functioning pumps, you want to have good functioning vesicles, you want to have good functioning neurotransmitters, and only the amount that you need, not too much, not too little. And you want to have good receptors to be able to receive the message. If any of those things gets out of whack, you've got a problem, and especially if over time that can make the system break down, which is, of course, exactly what addiction does. So what drives addiction? Well, exactly as we said, neurotransmitters. Remember, there's a similarity between drug molecules and neurotransmitter molecules. Most drugs activate what we call the reward pathway. So I talked about these pathways, right? How important they are for us to be able to make quick decisions, to be able to see things and understand what they are, These pathways are very important to us, and we develop pathways especially during young adulthood, adolescence and young adulthood, when the brain is maturing the most. That's when we tend to develop the pathways that help serve us as adults, and that's through the process of what's called myelinization, which is the covering of this part of the axon with a sheath, right, which makes it go quicker, right? So we're going to look at, for most drugs activate what we call the reward pathway, or the pleasure centers of the brain, through one specific neurotransmitter. And there's many others involved, but just for our purposes today, we'll talk about dopamine. Right? Pathways for understanding addictive effects of drugs on the brain and behavior. So take a look at this top left corner first. 3 areas. You don't have to memorize this. It's just interesting. Ventral tegmental area. It's really a group of neurons right here at the center of the brain where the reward pathway begins. So this is a place that dopamine is synthesized. It's created and it starts to send out. This is the reward pathway. So the pleasure pathway, the reward pathway, it ends in what's called the prefrontal cortex. We'll get to that. The prefrontal cortex's importance in our lives, and it's very important, especially for higher thinking and decision making, right? But when we eat good food, when we have sex, anything that brings us pleasure, this is where things begin. And the VTA going to the nucleus accumbens, where dopamine is then released forward into the prefrontal cortex, where dopamine helps modulate the prefrontal cortex's functioning. So this pathway, boom, bang, this is set up for us. Think of it as an airplane's landing strip. Right? Once it's set up, it wants airplanes to land. And of course, when we have something that feels good, or we do something that works well, we make a decision that was a good decision, and there's reinforcement, this pathway gets reinforced and it becomes quicker to make decisions around the same subject again. It becomes easier for us to say, yes, let's do that same thing again. That felt pretty good. So this pathway, the idea of creating a pathway that you can move down faster, you're going to draw planes into the runway as quick as you can. Right? So if you look down here in the lower right, you can see things like heroin start at the VTA, alcohol moves right into nucleus accumbens. They all work, cocaine, heroin, nicotine, all these work in helping to change the modulation of dopamine, either drawing too much of it or not enough of it, or helping to, in a sense, create a pathway just for each of their substances into the prefrontal cortex. So if we look then at the results, so where is this going to impact on? Many different drugs impact on different areas of the brain, but this front part especially in the reward pathway, because our body is set up to deal with pleasure in this way. Right? It has to do with voluntary control of skeletal muscles, personality. Right? So if we have substances, and when someone's chemically dependent, if they have damage to their reward system, right? You can see how changes of personality may occur. Someone who is passive becoming aggressive, someone who is aggressive becoming passive, things like that. It also is the home of the higher intellectual process area. The prefrontal cortex takes up the majority of the frontal lobe. It's what we call the executive suite. Right? It's where concentration, planning, decision-making is made. So here we have substances that are going to damage and harm the body's ability to modulate dopamine, which is going to impact on their ability to concentrate, to plan, and to make decisions. Right? I always like to think of the prefrontal cortex as a place that we get to say things like, on second thought, maybe I ought not to do that. My friends are all going out at 3 o'clock in the morning to go drinking at our neighborhood bar. On second thought, maybe I ought not to do that. A fully functioning prefrontal cortex means that you have, and a mature one means that you have the ability to say, on second thought, I ought not to do that. If it's not working well, or if it's been damaged, or the ability to modulate dopamine is harmed in some way, you very well may not be able to do that. You may not be able to say, no, I'm not going to have some heroin today. No, I'm not going to go out. No, I'm not going to do this other dangerous activity. No, I'm not going to bring a gun with me, right? Because you're not saying, no, on second thought, that's a bad idea. You got nothing inside which is stopping you, or you're not capable of making that decision. So prefrontal cortex, very important. Matures, by the way, for those working with adolescents and or young adults, right? Doesn't mature by the age of 18. The prefrontal cortex is the last part, the front part of the brain. The brain matures from back to front by about the age of 25 or 26. So that means that anybody up to that age is going to have, to some degree, problems with decision-making, concentration, and planning. And of course, the further you are away from full maturation, the more problems you're going to have. If you add in damage to the reward pathway and to the prefrontal cortex through chemical dependency, right, then you've got even more incapacity to work in these ways. Of course, the only people who have this really right are the car rental companies who won't rent you a car until you're 25 or 26 because they know the science. You got to appreciate that. Again, modulated by dopamine, which is a key neurotransmitter in this process. So let's take a look then briefly at some of the science results, right? So what are PET scans are scans like MRIs that take scans either in layers of the brain or different parts of the body, or it can take images like this, which can show us how many receptors somebody has. Over time, what can happen, of course, is receptors or any of the pieces of that work within that synapse can be damaged. If receptors are damaged in the reward pathway, you've got the need to move things forward, to bring that airplane down to the landing strip, right? Because the lights are on, the runway's there, but the runway's a little damaged, right? The receptors may get broken. You may not have the capability or ability to feel pleasure in the same way that you had originally. All these things may happen. So brain scans then. Drug users have far less dopamine activity, so that's on the right here, as indicated by the depletion. So the dark red shows disruption compared to the controls on the left. So here's the normal functioning brain, right, with dopamine activity, and then here is significantly less. You can see this especially in the prefrontal cortex, right, in the front part of the brain, how this can lead to incapacity. So loss of control and incapacity. Right? Studies show that this difference contributes to dependence and brain disease. So this is one interesting way to look at it. And so how does this then impact on us as drug court workers? What do we see, hear, sense from our drug court practitioners? Well, we see that folks have developed tolerance, and of course tolerance is a symptom in the DSM-4 of dependency or addiction. Tolerance simply means that at first it may have taken you 2 beers to get high, but months of continued use later, now it's 6 beers. So your body develops the ability to process the chemicals neurochemically much quicker so that you can run through the process faster. The problem is the pleasure centers are also lessened because of damage that occurs to the receptors. And so you need more and more of a drug to get similar or to try to approach that same response. When using heroin, it's sometimes called chasing the dragon. That's an old term, but that idea that you're constantly trying to chase that first high and then never achieving it, as dependency kicks in, so that we say someone is no longer using to get high, but they're using to get normal, to be able to function. So the reasons for, go back to those first 2 questions that you guys answered, right? The reasons why people initiate substance use and then the reason why they continue to use over time when dependency sets in are very, very different. So tolerance is one. Withdrawal, of course, is another. And withdrawal occurs then because you've got the runway lit up, you've got the runway ready, you got the lights, you're signaling, you're looking for planes, you say land the damn plane, and of course no planes are landing, right? So withdrawal means that you're going to have symptoms then of some sort, physiological, psychological. So for heroin, for example, besides craving the drug, depressed, anxious, irritable, aches and pains, sweating, night sweats, tears, runny nose, that kind of thing, bad diarrhea, nausea, vomiting, insomnia. So many times people will say, generalizing, that the opposite of the rewards then occur during withdrawal. These signs or symptoms, depending upon how long someone has been using and how deep into dependency they are, will be more or less severe. Right? But they are clearly a deterrent. When those messages come in of pain, nausea, diarrhea, all those things, when the body responds in this way, these are other ways for the body to say, you better pick up and start using again. So decision-making capabilities are diminished exactly as we talked about because of the impact on the ability of the prefrontal cortex to do its job, right, to allow you to make connections and make decisions quickly, rapidly, effectively, and in healthy ways. So then, of course, their behavioral responses, loss of control, as we've been talking about, continued compulsive use despite harmful consequences. So this is when you say, hey, but, you know, she's using meth, the baby's on the floor, nobody's getting any food, the place is a mess, there's fire hazards everywhere. How can they ignore these things and continue to use? It's not a simple answer. Dependency has its way of helping people to see what they need to see to continue use, right? And to not be able to see these other things. It's about capacity. You lose the control to be able to see the world in a clear fashion. You lose control of the ability to make decisions that would be helpful to you. If you don't have the ability to say, you know, on second thought, I ought to use that money for milk for my kids. If you lose that ability, then what are you going to do? Oh, I'll simply get it to use substances for myself. Because you don't have the ability to say, on second thought, I better not. You don't have the ability, capability, right? It is significantly less, or it may not be there at all. And of course, the idea of multiple relapses preceding any kind of stable recovery. It doesn't have to happen, but the odds are good that it will. So then the issue of what we call continued treatment. This was interesting because we can come back to this from the very first thing I talked about with regards to how long should someone be in treatment. So here's a little of the studies of the brain that can show us or give us an answer to that. So on the left you have the normal brain, right? And there's something about saying normal brain which just makes me laugh. But nevertheless, the normal brain over here, here's your brain on drugs kind of thing. Here's your brain after coming off of drugs, and specifically methamphetamine. So 1 month abstinent, look at the difference between here and here, right? These are the number of dopamine transporters and receptors inside the brain. Red is high number, then orange, then yellow, then green, then blue, which has the least number. So you can see the dopamine transporters and receptors are all in the same place. This is the reward pathway we've been talking about. And so at 1 month, there's still, what this means is there's not a lot of capacity for feeling. There's not a lot of capacity for concentration, decision-making capabilities, which of course when we work with methamphetamine addicts, right, we have them in highly structured programs where they don't have to make a lot of decisions about what should I do today, right? What should I wear? Where should I go first? I mean, and this makes sense because that capability is significantly, as you can see, diminished here. And then if you look over here at 36 months, so really hear this, 36 months, right? 3 years in, and you just about got capacity back, but it's still not as big. This area is still not as big as this area over here. So even at 36 months, and this is going to be drug by drug, right? It'll be dependent on the specific drug, how long this takes, but we're talking about treatment over a period of time to help people to get back to some kind of normal, right? So which do you think works better? I'll put this poll up for you guys. Tell me, which is better, jail or drug treatment? Give me 1 second, and I'll get the poll up for you. And you tell me. Click on this on your screen, and all the information will come to me. And we'll be able to tell in a relatively quick time. Here we go. I got 60% voted, 70% voted. I've got a screen which gives me all this wonderful information. 72%. For those who haven't voted, hurry up, get your last votes in. Let me see if I can get up to 80% of you who voted in. All right, let's close the poll and let's share the information. So which works better? Just about everybody says drug treatment, and I'm preaching to the choir here. That's not a bad thing. But some folks are still looking at jail and saying, you know, jail works better. It really can depend on what you've seen, what experience you've seen, and of course, what pathways in your brain have been impacted by external stimuli, meaning what you've seen in your job. Remember, the outside world impacts these pathways just as much as the inside world does too, and our substances that we take in. All right, so let's take a look then real quickly at how all this information impacts on impacts on our work, right? So here's a bunch of studies collected by Richard Rawson on re-addiction following prison. So how many folks, these are mostly opiate addicts. Let me get them all up for you to see first. And then just take a look. So look at the numbers, right? 3 studies, about 1,400 opiate addicts go to prison, addicted, come out of prison, re-addicted, 91%, 98%, 88%. So that's mostly opiate addicts. And we know already that heroin's right up there on the top, right, when it comes to the drug all by itself. You know, the chance of prevalence of addiction over a lifetime is higher than just about everything else. So what do you have? Look at the last study, 237 mixed addicts. Even then, 70%. So how effective is prison going to be for treatment? Clearly not very effective. So then it does kind of beg the question of what about long-term studies 3 years out in treatment or longer for other types of drug treatment programs, right? And this is overall alcohol programs, cocaine programs, and methamphetamine programs. So take a look at these numbers. All right, multiple studies on alcohol reporting a majority of alcoholics who enter treatment experience multiple relapses and retreatments with about 30 to 50% achieving stable abstinence. So 30 to 60 to 50% success over time, right? 10-year follow-up for cocaine dependence, about 50%. Most re-enter treatment multiple times. Methamphetamine, 50%, 3-year. So clearly, we would love to see 100%, but that's just not the reality of drug treatment. It's not the reality of chemical dependency, the brain disease, right? It's a chronic illness, takes place over time, with no cure, but with periods of stability and recovery. And of course, part of our job is to help people to get into that stable period of recovery and then stay there, right, for as long as possible. So some of the public expectations, I think, that are out there around drug abuse prevention interventions, and of course, even I think some drug court practitioners, some of the things that we think is that drug treatment, you know, it should be just safe. You do it. There's no harm to you. There's no worrying about seizures, about illness, about harming yourself or anybody else while you're in treatment. You just complete detoxification. It occurs. There's a reduced use of medical services. It eliminates crime in treatment. Return to employment, self-support. There's no more family disruption. And of course, there's no return to drug use. So what do we know about the reality of addiction, of chemical dependency as a disease? Well, it's actually not what's up on the board. Right? It's much more complicated. There are biological, psychological, and social factors that we have to address in treatment. And because it's so multidimensional, it makes it harder. Not impossible, but harder. And it's longer term. We'd like everything to be simple. It's not. Right? So neuroscience supports that addiction is a brain disease. Just remember that. Biological, sociological, and psychological components. So some of the impacts that we have then are remembering, number one, that addiction is a brain disease, not simply behavior. That there's an impact on cognitive functioning, right, which means that what is said, heard, interpreted, acted upon, all of these things are going to be influenced by damage to the brain, to the reward pathway in particular, to the ability of the prefrontal cortex to do its job for us, right, to be able to concentrate, to be able to comply, to be able to remain abstinent, which of course brings us to this idea of the concept of mitigating circumstances for a brain disease. It means that we have to start thinking about, besides doing a good job in assessment, if someone is chemically dependent, if the DSM-4 diagnosis occurs, we have to recognize that this means that there will be challenges to treatment. We may expect people to comply, to remain abstinent, to listen, to be able to follow a plan. They may not be capable of doing these things, which will require more intensive treatment. And this is all about trying to figure out, based on assessment, what is the best place to put someone to help them recover from this brain disease. And of course, how you view and react to relapse, which is a huge issue for us in the land of drug court, because treatment providers tend to recognize that relapse is a big part of the process for just about everyone. But many times, as criminal justice folks, it's a real challenge to see and to be able to react in an appropriate ways based on an individual's capability, based on where they are in this brain disease. Right? So what we'd like to work with then is what we call a chronic care model, and this is what we'll work with in our next 2 sessions, seeing how our brain science can influence this. Detox, a duration determined by performance criteria, like the ASM criteria. Rehab, continuing care in recovering patients. So rehab meaning treatment of some sort, usually 90 days plus, depending upon the intensity needed, inpatient, outpatient, and then continuing care afterwards. Lessons learned from chronic care. Remember, behavior change is necessary for sustained benefits. That treatment effects do not last very long after treatment stops, which is why relapse can occur and why multiple episodes of treatment are going to be needed. But within a larger concept of chronic care, patients not in the same form of treatment or monitoring are at greater risk for relapse. Retention is critical, and monitoring is essential. Of course, one of the things we do really well in drug court is monitoring, and it's one of the reasons why we're so successful, right? So with that, we have about a minute to go, and if you have some questions or a question, why don't you type them in, and I'll be glad to answer them before we close out. We've got about 2 minutes or so before we're finished. Okay, here's one question. Some programs have policies which declare potential participants ineligible for drug court if they have previously participated in that drug court. Would this presentation give credence to revising this policy? Yes, it would. From my perspective, sure. Doesn't it make sense that if you know that people are likely to leave and come and go from treatment, that you may very well, depending upon their level of use, if they are chemically dependent, they probably have some kind of long-term substance use that's been in place. There's been changes in their brain. You will probably see those individuals again and maybe again. And they're probably going to need the longer-term treatments, the more intensive ones also. So it makes sense to look at that as an eligibility requirement and to really be cognizant of how brain disease is going to impact on that. So what is retention? Keeping people in the program. Right, so for just in a real basic way, this is the question: what is retention? If an individual, so graduation, retaining someone to graduation until they finished all the requirements for graduation. If you lose them before then, we know that their outcomes are not as good with regards to recidivism for either substance use or criminal behavior. Okay, so with that, I think we're just about out of time. I want to thank everybody for checking in on part 1. We've got 2 more parts that we'll be working with. Let me give you a brief look at what they will be. Addiction, the neuroscience of the brain, part 2. So we'll look at the biopsychosocial spiritual factors impacting addiction and early recovery, as well as client participation in the drug court program. So we'll take the neuroscience and look at those 3 areas even more critically. And then we'll look at relapse as part of the last piece. On September 27th. So same time, same place, next 2 weeks. As you sign out and as the webinar ends, please make sure that you fill out the evaluation that's critical to American University and, of course, to us here at NDRI and, of course, myself, because I get a chance to look at them to see what can be done better for next time. Please don't forget, complete the survey. Thank you for participating. Thank you especially also for Clyde Fredericks, the Senior Administrative Technologist, our organizer for today's webinar, who the reason the technology works so well is because he's here to make it so, as they say. So with that, thank you very much, folks, and I look forward to seeing you again next week.